just now the blood vessels and your venous drainage of the neck, head and neck region, and lymphatics. To easily memorize, you just OA 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That is very difficult. Very difficult. You have to need to know the major vessels which is supplying the head, neck and brain and their location. So, I showed you in the slides that there is little difference between the right and the left of the origin of the brachiocephalic vein, artery. Now, with this beginning, I am just telling you, I will go through and you look into the specimen yourself, and then you can go for planting trees. Trees, you can plant trees, big trees, you can, replantation. Okay, now thyroid gland, situation in front and the opposite side of the trachea, opposite 5th, 6th and 7th cervical vertebra. See. Special features unique among endocrine glands that it manufactures, store and then release the hormones. What is the unique feature of the thyroid gland is that it manufactures, stores and then release the hormones. Only endocrine gland that depends on external environment for manufacturing its hormones. Richest blood supply, normally not palpable. Normally not palpable. It is normally not palpable. But if you see any swelling over here, you just ask the patient to deglute. Jalkan, dhok gilun, drink water, pio, and you see the thyroid gland moving up and down. Okay, if there is a cystic nodular structure, then it will go and ask to protrude the tongue, then it is the thyroglossal cyst. These are the two differences, and the location of the, I have a very bad throat, 10 days I am suffering from temperature and all this. Anyway, the regions of the submandibular gland, sublingual gland, preauricular gland, these glands, neck glands, you know the location. Now, thyroid gland is over here. It has two lobes. It has an isthmus, and if you see the posterior, when you dissect out posteriorly, you use parathyroid glands. This is one thing. Now, you see your coverings of the thyroid. It has a true capsule formed by thickening of the fibrous stroma of the gland, and false capsule derived from the splitting of the pretracheal layer of deep cervical fascia. Pretracheal layer of the deep cervical fascia. And true capsule is formed by thickening of the fibrous stroma of the gland. Tracing of capsule above to the thyroid bone in the midline and to the oblique line of thyroid cartilage on each side. Below it, pretracheal fascia enters the thorax and blends with the fibrous pericardium. False capsule is thin along the posterior border of the lobes due to the thyroid tumor. Due to this, thyroid tumor grows posteriorly without visible swelling in the front. So, if there is a thyroid tumor, it grows because of the weakness of the absence of the posteriorly the capsule. So, it grows that way. It's not suddenly it becomes big goiter, or if it is a small tumor, it grows excess posteriorly. Now, you see why thyroid gland moves with deglutition. Now, this is important. Why thyroid gland moves with deglutition? That's what I told you. That the false capsule thickened to form the ligament of Berry connects the medial surface of the thyroid of the gland with cricothyroid cartilage. Thyroid gland is identified during inspection by asking patient to deglute and then by a finger placed on the structure which moves on deglutition. Here is the thyroid gland. Now, it has two capsules enclosing the gland. False capsule derived from the pretracheal fascia, thickened laterally, forming the lateral ligament of the berry, which fixes the gland to the cricoid cartilage. Now weight 25 grams, size female, the size is bigger than the male, increasing during pregnancy and menstruation, consists of two lateral lobes and one isthmus which connects the two lobes. Pyramidal lobe presents 40% of the cases. This is the pyramidal lobe, the anterior view, right lobe, isthmus, left lobe. Superior parathyroiditis, the parathyroid glands, inferior parathyroids. Now each lobe is pyramidal in shape, measures length in 5 centimeters, breadth is 3 centimeters, thickness 2 centimeters, presents apex, base and 3 surfaces. Anterolateral surface, posterolateral surface and medial surface. 3 surfaces, anterolateral surface, posterolateral surface, medial surface. 2 borders, anterior, posterior. Again, apex directed upwards towards the oblique line of the thyroid cartilage. The thyroid cartilage is, you can see the big cartilage here. Sandwiched between the inferior constrictor medially and sternothyroid laterally. These are the 2 muscles. This thyroid enlargement cannot extend above. That's why see the thing, the huge goiter, it doesn't extend like this. Restricted. It's restricted there by this constrictor muscles. Now, it is important to ligate the superior thyroid artery close to the gland to avoid injury to the nerve during thyroidectomy. Okay. Now, near the apex, the superior thyroid artery and the external laryngeal nerve diverge from each other, and away from the apex, they come close to each other. See, this is the so during surgery, it is needed to ligate the artery close to the apex to avoid injury to the nerve. Base directed downwards and extends up to the 5th and 6th tracheal rings. 5th and 6th tracheal rings. Okay. Now at the base, it is related with the inferior thyroid artery and recurrent laryngeal nerve. Near the gland, these 2 structures come close to each other, but away from the base, they diverge. So during surgery, the inferior thyroid artery is ligated away from the gland to avoid injury to the recurrent laryngeal nerve. During thyroidectomy, your head neck surgery, you can identify. So it's not easy, but you have to know the location and identify, and just with a small retractor, you place the nerve and then you ligate the artery. And then you dissect out, and now this is very important. In viva, it can be in short note, and especially these components. Then your capsule, true capsule and false capsule. Now you see lobes, lateral lobe surfaces, anterolateral surfaces overlapped by the muscles of the neck in the sternothyroid, sternohyoid, superior belly of omohyoid, and part of the sternomastoid. Now all these neck muscles, we just name them 1, 2, 3, 4, even this thing, that covers the thyroid. Now medial surface is related to the rule of 2. Just to remember, medial surface is related with the rule of two. Tubes, larynx and pharynx, tubes. Larynx here and pharynx. And muscles, inferior constrictor and cricothyroid muscles. The muscles, inferior constrictor and cricothyroid. Nerves, external laryngeal and recurrent laryngeal nerve. This external laryngeal rule of two. It might be a short note, rule of two. Or it can be an MCQ, rule of two. Okay. Now, lateral lobes. Lateral lobes, posterolateral surface is related to the cricoid sheath, carotid sheath and its content. Borders, anterior border separates the superficial surface from this medial surface, passes downwards and accompanied by anterior descending branch of superior thyroid artery. Posterior border separates the medial surface and posterolateral surface, and association between superior and inferior thyroid arteries, parathyroid glands, thoracic duct on the left. See, this is the parathyroid gland, this is the thyroid gland, this is the recurrent laryngeal nerve, this is the esophagus, superior laryngeal nerve, and muscles of the pharynx, this is the larynx. Now, isthmus connects both the lobes across the midline, this is the isthmus. Vertical and transverse diameter are 1.25 centimeters. Present two borders, upper and lower border. This is upper border and lower border. A pyramidal lobe occasionally extends upwards, upwards from the isthmus close to the midline. This is the pyramidal lobe. And sometimes a fibromuscular band, the levator glanduli thyroidea, extends from the thyroid bone to the isthmus of the pyramidal lobe. It is situated, it is a striated muscle, this thyroid bone here. Lower border, inferior thyroid vein is related to this border. Now, arterial supply, superior thyroid artery, branch of external carotid, the inferior thyroid artery, branch of the thyrocervical trunk, arteria thyroidea, occasionally present, branch of brachiocephalic trunk of the arch of the aorta, it supplies the isthmus. And accessory thyroid arteries derived from esophageal and tracheal arteries. Arterial supply of the gland, this is important, a short note. You draw a diagram and represent the different arteries that is supplying the thyroid. Now, venous drainage. Now, arises from the venous plexus deep to the true capsule and drained by superior thyroid vein, drain into the internal jugular vein. Middle thyroid vein, drain into the internal jugular vein. Inferior thyroid vein, drain into the brachiocephalic vein. Sometimes a fourth thyroid vein, Cocker's vein, arises from the lower pole and drains into the internal jugular vein. It may bleed profusely during surgery, so should be searched and ligated before surgery. Lymphatic drainage, you can see the lymph nodes here. Lymphatics from the plexus around the thyroid follicles and the vessels are arranged in two groups, upper and lower. Upper group drains into the pre-laryngeal and jugulo-digastric lymph nodes. Lower group drains into the pre-tracheal and group of lymph nodes along with the recurrent laryngeal nerve. Histology of the thyroid gland. I think I just go through round or oval follicles, a single layer of cuboidal and lower columnar epithelium called follicular cells secrete T3 and T4. Lumen of the follicle contains colloid, which is pale inactive follicle, and deep inactive follicle stored thyroglobulin. Parafollicular cells, also called C cells, they are scattered between the follicular cells and between the follicles. C cells contains clear cytoplasm with oval nuclei, difficult to identify in each stage, derived from neural crest cells that secrete calcitonin. Now, development of the thyroid, endodermal diverticulum, thyroglossal duct. Now, thyroid development foramen cecum, site of origin of thyroglossal ducts between floor of the branchial arches of 1 and 2. This is the thyroglossal duct. Now, this is the hyoid bone. This is the thyroid cartilage, larynx, and this is the thyroid. This is the sternum, retrosternal thyroid. Okay, endodermal downgrowth of the thyroid epithelium, developing tissue invades hypobrachial mesenchyme and branchial mesenchyme, which gives capsule and septa. Site of thyroglossal cysts move up with protrusion of the tongue. জিভটা বার করতে বলবে মা কালীর মতন। Have you seen goddess Kali's portrait? ঠিক আছে, আবার যখন জিভ দেখাতে বলবি পেশেন্টকে, এই জিভ দেখাও তো, দেখাও, জ্বর হয়েছে। হ্যাঁ, you have to, by tongue you can diagnose many diseases. And one very common, anyone with pyrexia, thyroid, I mean this thing, typhoid, a thick coated tongue will be there. So when you go to clinics, Hutchinson's Clinical Methods, that's a book. I don't know about the Indian authors. And Dr. Sen's, there was one book in our time. But who was the physician to Uttam Kumar, the actor? Okay. Now, in clinical methods, you have Indian books, but carry 2-3 books throughout your life. That is Hutchinson's Clinical Methods. Then K.P. Das, his son is editing your Clinical Methods in Surgery. These are books you will say. Of course, now with digitalization and advancement in your publishing books is really at a biplab. You can have very wonderful pictures in the thing. You just click and see. You know more than me, and download the structure of this tongue and your what are the indicates. Okay. Now see the endodermal diverticulum, the thyroglossal duct, stroma, thyroid follicles, double cellular plates which formed after repeated division of lower thyroglossal duct within the thyroid mass. Synthesis of hormones starts between 18 to 20 weeks of intrauterine life. Fetal pituitary thyroid axis works independently of the mother as TSH does not pass through the placental barrier. Pituitary thyroid axis works independently of the mother as TSH does not pass through the barrier. Now, this development will be applied to the thyroid. Now, thyroglossal cysts, 7% of the population has remnants of thyroglossal duct. Cysts anywhere along the length of the duct, 60% infrahyoid. This is the thyroid, this is the hyoid bone. So, infrahyoid in this region is the cricoid cartilage. This is the cricoid cartilage. In this region is mostly present. Okay, but it can be in the inner part of here. Now, of course, it's become easier for the previously your general surgeons used to operate and few ENT surgeons. Now, in super specialty, it is the domain of the ENT surgeons, and you can locate by MRI, CT, and naturally nowadays I refer my patients to one of our junior colleagues, Professor Manoj Mukherjee. He is a brilliant head neck surgeon, and naturally I have left. I am leaving many things. As I am aging, I am leaving many things. Anyway, 1 to 2 centimeter cystic mass is mobile on swelling and protruding of the tongue. I told you when you just deglute swelling, then it goes round like a marble, a cystic swelling. Okay? And you protrude the tongue like this. Okay? Now, see, this is the picture here. Situation contains thyroid tissue. Malignancy is rare. Acute infection contains mucus-like clear fluid. If it is becomes symptomatic, it must be removed. Cyst trunk operation. Now, lingual thyroid, failure of thyroglossal duct to descend, a mass of the foramen cecum. The left tonsils, the uvula, the lingual thyroidea, and tongue here. Asymptomatic or present with airway obstruction may be the only thyroid tissue. Now, you have to, it is the only thyroid tissue. Now, you see a swelling, you become over enthusiastic, usko kaat diya. Then blunder. So you have to have a thing always in mind that you have to diagnose anatomically, you have to think and then refer to your surgeon. You see over here, just do an USG for thyroid. So if the thyroid is there, then it's no matter. But over there are swelling that can be a tonsil, it can be a lingual thyroid. Now, ectopic thyroid tissue anywhere along the migratory route of the thyroid, mediastinum, larynx, trachea, pericardium, or esophagus. Now, anyone is having he or she is answering amongst you for a gold medal, and though the examiner might ask, what is ectopic thyroid? May ask. Even it can be a short note. What is ectopic thyroid? Then you have to just see anywhere along the migratory route of the thyroid and mediastinum, larynx, trachea, pericardium, esophagus. Ectopic. Pregnancy, ectopic pregnancy. It is outside the normal. Now, congenital intrathyroid cyst present in children, persistent ultimobranchial bodies or intrathyroidal thyroglossal cyst. The large multinodular goiter. Here, colloidal goiter. This is a total thyroidectomy for dysmorphogenic goiter. Now, these are things that can be investigated through MRI, CT, and also USG. Most common is the USG. Don't go for an MRI. And after swelling, take a MRI. You do USG. USG is a very, very good, and I feel it is at times, see, when you do a MRI or CT, they tell you, the radiologists will tell you that you do an USG. It looks very funny. So do an USG 1,200 rupees or 1,500, but don't go for an MRI neck for 6,000 rupees. This is the thing you have to be, your clinical knowledge. I'm always, from the day one, that you develop a clinical acumen, you develop a clinical knowledge that will help you till your last days of life. तुम जब बुढ़ा बुढ़ी बन जाओगे फिर भी डॉक्टर साहब देखिए. I met my father's teacher, Dr. Shoilen Mukherjee. My father was one of his best pupils. So we were celebrating 25 years of our nursing homes, 25 Silver Jubilee. I went to him and to give some writing. Then he just wrote regarding my father and the organization. But one lady, he is sitting in an armchair. He's sitting right there. She won't say, ডাক্তারবাবু আমার হাতটা তুই টেনে দে, আমার বাচ্চা নাতির হাতটা টেনে দে, একটু প্লাস্টার করে দে বাবু, একটু ব্যবস্থা কর বাবু। বলছে দেখ আমি এখন করি না, ওই করি না বলে না, তুই গায়ে হাত দিলেই ভালো হয়ে যাবে। আমার নিজের আমার বাবার শিক্ষক। You go to Calcutta Medical College, you will see, if they have not thrown it away, he was a very good painter. And some big canvases in the auditorium, in the lecture theatre, are there of Sholin Babu. Sholin Babu used to do, even he did trifine and the craniotomy, and took out the blood clot of in the intracranial hemorrhage. He used to do orthopedics. What not? Physician, with every gait, any smell, he used to diagnose. Surgery, he used to do. So that was the day that time. Now I'm a part of you. Now we are having so many gadgets, but don't सब में AK-47 मत लगाओ. You just use simple tools. Just say one thing I tell you. I read in a journal that the brain scans. One physician, he studied multi-center. उसको brain scan का सब study करके, the most of the thing came normal. The brain scans. So he suggested that your simple hammer, your needle, these will give you a diagnosis of 75%. What is the loss? I'm saying 75%. That's why I'm telling you. You just be knowing things. You just draw in your prescription. Being an MBBS doctor, from day one you start. You see a patient, case history is very important. You diagnose, you draw a figure. You in a rush in the hospital, you have seen right hernia. Even in the table when I'm putting my patient, let's see the papers, then I see my right side. Again, I tell clinically, at this age, I've started my surgery from third year, and fourth year I was doing it independently. I got an opportunity, I did it. That's why my clinical knowledge, at least to some extent, I won't be boasting, but I'm telling it works. You have to do it. You can read, you're reading out this thing. Don't be frustrated. Don't be frustrated. I'll just tell you an incident that yesterday I released that patient. She had a big thyroid. She was opened twice, but whoever was this thing could not take it out. That I did the third laparotomy, and I was sure and I was determined that I will take it out. And without any complications, she was from Jamtara. It is on the main line of Delhi, this thing, track. Chittaranjan, Asansol, Chittaranjan, Jamtara. So she came, did it from my clinical knowledge. I didn't do a CT even. USG was done, she brought that to, I didn't do a second USG. But I was confirmed by vaginal examination, internal examination, plus external examination. So whatever you are studying, abhi adai mas ache, but when you go to third year, don't lose a day. Don't lose a day. But you go for, you just see, the next day you see, you have program of planting trees. That I cannot restrict you, but I won't restrict you because I changed my profile picture after a long few years, I think, in Facebook. You will see it, that I'm creating a plot for planting some rare fruits, fruit trees, and also bale, you know, at least 50 bale I'll be planting this monsoon, and I'm creating a plot and vegetable garden. Okay, I'm standing in front of the JCB. Thank you. দেখে নেবে চোখের দেখা দেখো চোখের দেখা এই স্পেসিমেন গুলোই থাকবে. Now naturally it will be acquainted. You will just be in acquaintance. If you go today, when you come tomorrow, if you have your dissection, please look into it. When 2 hours dissection, 1.5 hours. 1 hour you come with the current topic. Please listen to me. 1 hour for the current topic. Whoever is teaching you, you see that. Sit down. When and half an hour you revise. Take out specimens. They will help you. Hey, এরা স্পেসিমেন ভ্যাট থেকে তুলে দিবি, ধর হেডনেক হচ্ছে, হেডনেক যা দেখলো বা ম্যাডামরা দেখালো, স্যার দেখালো, হ্যাঁ, কিন্তু তারপরে এরা যদি কেউ রিভিশনের জন্য চায়, একটা আপার লিপ চায়, দিয়ে দিবি। আমি যেন শুনতে না পাই, আমাদের দেখানো হয়নি। আর একটা কথা বলি, প্রথম দিন বলেছিলাম, নো ওয়ান উইল টিচ ইউ, নো ওয়ান উইল টিচ ইউ। I had a feeling with my father never taught me, but he taught me many things by his silence. He used to teach the homeopathic medical college. He used to go do surgeries in homeopathic medical college, giving post-operative homeopathy medicine. So much guts he had, but he never told me you treat this way, that way, that way, that way. I think that he did the correct thing. But we are equipped you. We have equipped you. Actually, don't lose these 3 months, please. I'm just requesting you.